So our keynote speaker is Mark Duggan, who has just moved to the Wharton School at the University of Pennsylvania. And I can't remember how many years ago it was, but I ran into Mark, and I forget which conference it was at, and he leans over and whispers to me. He says, you know, I've just been asked to serve on the Council of Economic Advisors. And I remember saying, oh, Mark, you should do this. This is a lifetime opportunity. It's once in a lifetime. And just think of all the things you're going to get to learn, all the exposure. It's going to be a fantastic thing to do. And so off goes Mark to the Council of Economic Advisors, and he serves as a senior economist there, amongst all the other things he's done. And he was ideal for this position because not only does he do research in health economics, but he also has extensive experience in terms of studying our social security system and the disability system. So he was able to integrate a great deal of knowledge about the workforce into the recommendations he made about healthcare. And then I ran into him, I guess, the summer of 2010 at another conference. And after he was just about to finish his time at the council, and he looks at me and goes, "You were one of those people who said I should have done this, right?" And the look in his eye, and I thought, oh goodness. So hopefully he doesn't take it too much out on me when he gives his talk today. And with that, I'm going to hand things over to Mark, the Economist Invisible Hand and the Patient Protection and Affordable Care Act.
So it's really an incredible honor to be here talking about healthcare reform. I didn't realize that you had remembered that story. There was definitely an evolution of my, enthusiasm level as the time there progressed, and I can tell you a bit about that. It's funny, as I was finalizing everything for coming here, I looked at the title of the conference. I hadn't sort of caught yet the title of the conference, and saw this the good, the bad, and the ugly. And I thought, I don't really know that I can do justice to those three things with everything that I saw in my 15 months at CEA, but I'm going to try. So in any case, today I'll be talking about the Affordable Care Act. And it's funny, actually, I was here in Houston presenting in March of 2009, right after I had gotten this call from Christina Romer, who was the chair of the Council of Economic Advisors. And she had this is March 2009, so about a month and a half into President Obama's administration, and they had just gone through the whole stimulus package, and that had just been signed into law. And the president was really turning his attention in a big way to healthcare. And so when she called me and said, "Would you like to come work on healthcare reform?" I thought, I was sort of torn because I had a sense of how crazy my life might be if I were to do it. I have 2 young kids, all this stuff. But it was an incredible honor to be asked to go there. And so I ended up starting out in April of 2009 and serving through July of 2010. So I was there pretty much. I wasn't there during the whole Tom Daschle tax stuff, but I was pretty much right after that, right as healthcare reform was ramping up. I began there, and I was there, through the end and for the first few months of implementation. And so it was really, for me, it was a life-changing experience, an incredible opportunity to sort of try to apply some of the things that I had learned, during all my graduate training and in all my years of research, to try to make the bill a little bit better. So, the way that I thought about it, to the extent that I weighed in on certain things, and I'll talk a bit about this as we go through, by no means, it's funny because people would ask me after I had served, so this bill that you created, as if I lost much more often than I won. But I don't know, there were a couple small victories, and I felt good about that. And as economists often, I wasn't the only economist there, but I certainly was kind of in the mix, which was incredible, with some of the very highest players. And to some extent, the economist's role was often to sort of highlight unintended consequences, potential unintended consequences of policies, or to try to point out policy that sounded good, that would have good optics, that might, sound very good, might have a lot of problems if you really tried to implement it. So it was a great experience, and I really feel like I learned many things about the legislation. The one area I feel like I didn't weigh in on was the Class Act. So I don't know, maybe that was a good thing, I'm not sure, but they didn't ask us for help there. So in any case, I'll go through this now. Let me just see how. Okay, here we go. So I'm just going to start up. So pre-2009, the U.S. healthcare system had really, and this is not much different right now, but as we all know, the U.S. healthcare system had been characterized by rapidly rising costs in the private and public sector and an increasing share of Americans without health insurance. And these were really the two things that the president and others really wanted to do something about in sort of embarking on an effort to reform healthcare. And truthfully, it's a lot easier to do something about the second of these than about the first of these, as Amitabh and others this morning have alluded to. This growth in healthcare costs has just been imposing a really big strain on families, on employers, and on governments everywhere. And it is, I think those consequences are now starting to be felt. I mean, Amitabh showed that nice figure about the Medicaid and the spillover perhaps to other government services. And as this thing gets bigger, we're now at 17.6% of GDP, its spillover effects are going to be larger and larger. Going into this, if you were the president, let's say back in March 2009, do I want to sort of take this on or not? It would have been a reasonable thing to look at past efforts and say, I'm not sure I want to embark on this because it clearly was very difficult. Many previous attempts, Truman, Nixon, Clinton, and others, had tried to do this and just had failed. And it's, as you all know, it's an incredibly complicated system with many stakeholders, all of whom have different views about how to do it. So threading the political needle on this is very difficult, and especially if you're trying to do good policy while you do that. So it was a huge issue in the 2008 presidential election, in both the Democratic and the Republican primaries, and then in the general election. And so when Obama won, there were these huge majorities in both the House and Senate, and to some extent he might have thought then, well, if not now, when? This is a time with a lot of support. So just in terms of the signs at that point in late 2008, early 2009, I think there had been really strong support for the president with a big majority that he had won the election. And the passage of the Massachusetts health reform, I think, boded well, perhaps, for the potential at the national level. Although being from Massachusetts myself, a diehard Red Sox fan, for those of you I sympathize, we mean, they're Yankees fans here, you can leave. It was a rough year. I was there for game 162. It was bad. But obviously Massachusetts is by no means representative of the rest of the country. And there's probably nowhere where people would agree with me more than in Texas. But it gave some comfort, I think, to people who wanted to start on it that Massachusetts had been able to do it. And the one thing that everyone could agree on at the outset of this was that something has to change, because every year a larger share of people does not have health insurance. Every year costs are growing at an unsustainable rate, and so there was really a consensus on the need to do something. Of course, there were big obstacles to embarking on this too. At the time, as we all know, the unemployment rate was still growing. The stock market had, I think it was right around that time that I got the call that the Dow hit its low of like 6,500. And so I like to think that my decision to go to the CEA was responsible for the 80% rise in the Dow since March 2009. I'll be looking at your 401ks. I think it was just Mark signs on. Woo, there goes the Dow. The Clinton experience suggested a long and treacherous slog. That Tom Daschle, I think everyone thought that he was going to be the perfect person to shepherd this through. He withdrew, and then there were only the 58 senators. The Al Franken race still hadn't been decided, Franken-Coleman race, and Specter still hadn't switched. So there were only 58 senators, and as I didn't really know at the time, but it wasn't as clear to me back in March of 2009 how important the having 60 senators might be. Just quickly, I just want to, both the folks who have gone before this have gone through this, but just I want to sort of think big picture about the economics of health insurance before I go into the nuts and bolts of the reform, which are subsidies, mandate, and expanded coverage. And so basically, just in terms of thinking about the economics of health insurance, all of us are at any point in time, there are big risks that we have of very high medical expenses, and given that we're risk averse, we tend to buy insurance to guard against these risks that are imposed. And one possible policy, like a health economist's dream, would be to just transfer lump sum amounts of cash to people if they have different health shocks. You have a heart attack, here's $7,800. If you have a hip fracture, here's $4,700, and so forth, and just let them decide what treatments they want to get on the margin. Now, figuring out what those transfers should be is very difficult. That's why we don't see health insurance that looks like that, and instead, health insurance policies pay the cost, essentially, of health care. And that creates all the bad incentive problems that others have been highlighting, because then if someone else is paying for it, there's a big risk that people will get a lot more care than they otherwise would, given that demand curves slope down. There's no simple way around this inefficiency, which economists refer to as moral hazard, and this can be compounded by the asymmetric information problem, where healthcare providers have more information about than the individual who will rely on them for their expertise, and they potentially benefit from more care. So it's just a challenge in the system. And a related challenge in health insurance is adverse selection. If you're not careful, and this was probably most obvious from the discussion, David's discussion on the Class Act, there's a potential for adverse selection with health insurance, that people will only sign up when they're potentially going to get sick. That's especially true if you heavily subsidize insurance. If you have insurance that costs very little and people can opt in and out, then it's very vulnerable to adverse selection. And so, but the uninsured sometimes do need care, and so these kind of dynamics help to provide a rationale for the mandate. And beyond that, there's the additional sort of hidden tax that people refer to, the fact that the 51 million people without health insurance, they do get care, and that ripples through to higher costs for everyone. So just big picture, sort of think about the healthcare system, these issues of moral hazard, adverse selection, and so forth are sort of loom large everywhere that you look. In terms of the data on how things were trending when the president came into office, in terms of private health insurance, employer-sponsored health insurance premiums had been growing really rapidly, and they grew again rapidly last year. I didn't update this to the 2010 data when there was a 9% increase, but if you look in real terms, in inflation-adjusted terms, from 2000 to 2009, the family ESI premiums went up almost 70%, and that was during a period when earnings were actually pretty stagnant, so much that median household income actually declined during that period. And there's a causal connection between those two things, and others here, Amitabh most notably, have sort of looked at this issue that basically as healthcare costs rise, employers are going to necessarily pay less in wages to their workers, and so that ends up spilling through. So there is a real economic cost that individuals bear as health insurance premiums rise very rapidly. And partly because of these rising premiums, there's been a steady decline in the fraction of employers that offer health insurance to their workers. This is especially true at smaller firms and their employees, and this accelerated during the economic downturn. So if you have a look at sort of by employer size, what is the likelihood that employers offer coverage to their workers, from 2000 to 2009, you see, so the biggest employers, the General Electrics, the Intels, the Microsoft, they're offering health insurance to their workers. They're over to the right. But actually, the vast majority of employers in the U.S. are much smaller than that. And so if you look among employers with 3 to 9 or 10 to 24 employees, there's been a steady drop in the fraction offering coverage to their workers. And so, and this is, many people have sort of pointed to this as a kind of tax that the U.S. healthcare system imposes on smaller businesses and their workers, because to the extent that smaller businesses can't get as good of premium offers as the GEs and the Intels, they end up not offering coverage. and that makes it less desirable to workers to join those firms or to start those kind of firms in the first place. So it is, and this problem was getting worse and worse. So, one of the things that, one of the very first things that I was tasked with doing when I joined CEA was sort of studying the sort of whether and to what extent healthcare reform would impact small businesses. And it's funny because I think to some extent there are winners and losers from health reform. But if you think that if there's a segment of the economy that benefits a lot from healthcare reform, I think my nominee for the one that benefits most in relative terms would be small businesses. I think they get a huge benefit, and we'll talk about this as we go through. But as you can see, this was these rising healthcare costs were feeding through to lower wages, to lower offer rates, and so forth, and this was translating into lower rates of private health insurance coverage. So if we look at what fraction of kids are covered with private health insurance versus with public health insurance, typically Medicaid or CHIP, just over a 10-year period, 1999 to 2009, you see the fraction with Medicaid of kids going from 20 to 38%, and privately insured going from 69 to 56%. So if you looked at the fraction of kids uninsured, it actually fell during this period because the public more than offset the decline in private, the growth in public health insurance. But it's a change. This is really a steady trend that our healthcare system has been on, with fewer and fewer and fewer, a smaller fraction of the non-elderly population insured privately. And there are big differences across states in the share uninsured. And I sorted this, and you'll see I sort of thought, should I put this up? But it's just sorting 20 biggest states in the U.S. in terms of their fraction uninsured. And I'm not trying to be mean or but it is. This is not a place where Texas does super well. And so if you look, you're in good company. Florida's right there, California, Georgia, they're good. Those are great states too. But it's clearly an area where Texas, I guess Texas stands out from its peers here. And you can, that's right. So it is, this is, and as you can see, one striking feature about this, if you look nationally, is the share. I just put up the 20 states with the highest population here. But if you look, the share of non-elderly adults without health insurance, this is in 2009. These would be a little higher in 2010. Share of non-elderly adults without health insurance is about 2.5 times higher than among kids. So public policies have expanded coverage much more aggressively among kids than among non-elderly adults. But as you can see in Texas, almost 1 in 3 non-elderly adults was uninsured in 2009. So this is, to me, a good measure of the potential benefits, financial benefits to states stemming from healthcare reform. And one thing, the healthcare sector in Texas, if reform goes forward, if the state-based health insurance exchange is set up, if the Medicaid expansion with 100% federal match for the first few years happens, there will be a lot more money flowing into the Texas healthcare system. Because I think, and to me, if there's one state, I was saying this to folks last night, to my fellow panelists last night, if there's one state that I'm super curious to study the effects of healthcare reform on, it is Texas. I mean, Massachusetts, what's going to happen not much is going to happen in Massachusetts. And in my state right now, my current state, Pennsylvania, some will happen. But Texas stands potentially to benefit enormously, at least on this measure, at least as based on this measure. So I'm going to be interested to see how enthusiastically the exchanges, the outreach for Medicaid and so forth occur. Just in terms of pre-reform trends and overall costs, so healthcare is now at about 17.6% of GDP, and it's projected by CBO to grow to a third of GDP by 2040. And some of this is due to demographics, but the vast majority is due to excess cost growth. And Amitabh summarized this better than I could earlier, that the Dartmouth Atlas suggests that a lot of this spending is wasteful. And this is really imposing a growing strain on government budgets. And the one way that I think about it, you think of Medicare and Medicaid right now. So in 2011, Medicare and Medicaid will be basically $1 trillion in spending. $950 billion, $1 trillion, somewhere in that neighborhood. 310 million people in the U.S., about $3,200 per person in average costs from that program, $3,200. And we are on the precipice of a huge Medicaid expansion. So right now, 1 in 6 people in the U.S. are on Medicaid. According to CMS, by 2015, more than 1 in 4. So 25.6% of U.S. residents will be on Medicaid in 2015, according to CMS. The number of elderly people, David showed this earlier, is projected to grow by about 85% from 2010 to 2030. So Medicaid and Medicare right now are big, and they are set to grow quite a lot over the next 5 years in case of Medicaid and 20 years in the case of Medicare. So it's going to be what happens with these programs is going to be a huge determinant of how our healthcare system does. And all of this, the growth in private premiums, the growth in Medicare and Medicaid costs and so forth, have effects everywhere on wages, on employment, on taxes, the future taxes that we're going to pay, on other government services, on the deficit, on economic well-being. So it's not to say, clearly some of this healthcare spending is beneficial, much of it, but most of it is beneficial, but it's going to ripple through to have effects on many other things as well. So in terms of the Affordable Care Act, really starting things off, the central question initially, just the big picture, first order question, how big is the plan going to be? So in terms of the costs of it, are we going to try, so there were 50 million uninsured, are we going to try to get all 50 million covered? Are we going to try to get 15 million covered? Are we going to try to get 30 million covered and what have you? And so that was really one of the big issues early on. What kind of, what size has the political support, is good policy, and so forth. Ultimately, the bill that was signed into law of March 2010, the projected cost is about $900 billion from 2010 to 2019. The estimates suggest that there will be 32 million more with health insurance by 2018 than with no reform. Though I will tell you, I'm sure for those of you who have looked much at the ACA, it is incredibly complicated. So this 32 million, I myself sometimes say, 32 million more people covered. There's some uncertainty around that number, how big this coverage expansion will be. And so the economists and statisticians and others like to talk about confidence intervals. CBO doesn't present confidence intervals with their numbers, but they do make it very clear that there's a lot of uncertainty around this. To the extent that ends up being true, if it is true, that'll be about a 60% reduction in the number uninsured below what it otherwise would have been. And all of this, that 900 billion and that 32 million, could have been much larger or smaller depending on various economic parameters that were set in the legislation. How generous are we going to make the subsidies for people to get health insurance? How large are we going to make the penalty for individuals who don't get coverage? How many are we going to provide subsidies for people up to 300% of the poverty line or 400% of the poverty line? Are we going to include a public plan? And to the extent that we expand Medicaid, how much is the federal government going to share in it? So there were so many different variables. Any variable that you moved could have a huge effect on that 900 billion. And one underappreciated thing about the legislation that it does, it not only has subsidies for premiums, it also has cost-sharing subsidies. So to the extent that you have a plan, you might get a subsidy to buy that plan, but then there are additional subsidies depending on your income to help you with co-pays, deductibles, and so forth. I'll talk a bit about that as it goes through. But the thing that made this especially challenging was that the president made clear from the outset, to his credit, I think, that it had to reduce the budget deficit, at least in the estimation of the Congressional Budget Office. And I never knew how powerful the CBO was, but they're pretty powerful because they score all the legislation, and that ultimately is going to decide, does it reduce the deficit or not? This is very different from Medicare Part D, which obviously just there weren't offsetting revenues or lower savings elsewhere. So any increase in spending that would come from covering these 32 million people, these 32 million new people, had to be matched with lower spending or higher taxes elsewhere. And every single dollar was controversial, right? Every person, you can point at You can't, if you tax me, then I'm going to work less hard. That's going to harm economic growth. If you pay hospitals less, they're going to do, nothing was easy with this. And so that made this, if we had been trying to pass this in 1999, when we had a $200 billion surplus and the CBO was saying that we're not going to have a federal debt anymore, or maybe it was the Fed, I'm not sure, it might have been a lot easier. But this made it very, very hard. And of course, progressives and fiscal conservatives and many others had completely different views about this, how to do it. We should cover everyone, we should make everything free, or then we should cover no one. And so it was fun to watch. So the key provisions of the reform, in terms of the health insurance coverage, Medicaid expansions are set up so that people with incomes below 133% of the federal poverty line are covered through Medicaid. So what amount of money is that? Well, for a family of four, let's say, the poverty line is about $22,000. So a family of four making $30,000 a year or less with household income would automatically be eligible for Medicaid beginning in 2014. Everyone, not just the kids, the adults too, would automatically be eligible for Medicaid. And these expansions are financed almost entirely by the federal government. So in Texas, this is going to be a huge deal. There will be a lot of people who are under 133%, who aren't currently eligible for Medicaid, who will become eligible for the program. And this actually accounts for half of that gain in health insurance coverage. 32 million newly insured, half of it is coming from the expansion in Medicaid. Okay? Because there are a lot of people, you're much more likely to be uninsured if you have low income. So going just up to 133% of poverty, of the poverty line, that affects a lot of people. Second one is the state-based health insurance exchanges. And these are going to allow individuals to shop for different plans. The hope is that several insurers will participate and offer plans of varying generosities with varying prices. And there are subsidies for people to purchase these premiums in these exchanges. So I think the next slide, let me see if I'm going to go forward and then come back. These subsidies look like this. So if you look for a family of four with a $12,000 policy as the family income, basically the subsidies sort of phase out with the person's income. So the higher your income, the less your subsidy is. And yes, there are what are called subsidy cliffs. So if you go from $87,000 to $89,000, you lose a lot of money. And I'll talk about the economics of that. But this was an area where economists, I think, had a huge impact. How do you optimally set these subsidy levels, the rate at which they phase out, and so forth? Okay, sorry. Okay. And so this phase-out rate is about 15%. So one concern that economists might have about this is you're going to have a lot of people in these exchanges who are thinking to themselves, well, if I earn another $1,000, I'm going to lose $150 in subsidies. Maybe that will reduce people's incentives to work. So that's something that is on people's radar screens. There's small business tax credit for low-wage firms with less than 25 employees to subsidize their getting coverage. But they don't have to provide coverage. If they want, they can just not provide it, and their employees can go to these exchanges. There's an individual mandate so that people have a powerful incentive to get health insurance. It's interesting, if you look, the people most likely to be uninsured are actually just about the lowest risk group. So I looked in the 2009 data, this has actually improved a little bit, but in the 2009 data, fully 40% of 24-year-old men in the U.S. were without health insurance. So they're the group who's most likely to be uninsured, and this mandate will encourage more of them and their counterparts, similar ages and so forth, to get coverage. Okay, employer responsibility for firms with 50 or more employees. So one thing, this was a place where economic research had a big impact. There was a concern about having this new program and employers saying, well, heck, there are subsidies available for my workers. I'll just let them go get the subsidies. I won't offer coverage, and I'll save a ton of money. So there's an employer responsibility requirement for a firm if they have 50 or more full-time employees. And that's to reduce crowd out of existing employer-sponsored insurance coverage. So these subsidies, why do we have these subsidies that are large and phase out with income? Folks with low incomes are much more likely to be uninsured. People in poverty are about 6 times more likely than people at 5 times the poverty level to be uninsured. And the sort of composition of that insurance varies a lot with income. So if you look among people in poverty, less than 1 in 5 have private insurance versus 9 in 10 for those at 500% or more of poverty. So in terms of other key provisions of reform, the financing of reform, changes to Medicare, there were 3 big changes to Medicare. I'll talk a bit more about these in a second, but basically reducing, let me delay this because I have another slide on this. The excise tax on high premium plans, and this was delayed until 2018. This was actually a huge surprise to me that this ultimately ended up in the legislation. It was hugely controversial. Basically, if an insurer if a person has a policy with a health insurer that's above a certain threshold, they essentially don't get the tax subsidy that currently exists to employer-sponsored insurance beyond that threshold. And so the hope is the expectation of the Congressional Budget Office is that that's going to cause people to get less generous health insurance than they otherwise would, and that's going to help us to slow the growth rate of costs. Other sources of revenue that were some inside, some outside the healthcare system. So for people earning $500,000, $1 million, $2 million a year, there's a slightly higher tax on unearned income and earned income. And device, pharma, and health insurers have fees in proportion to market share. And Cosley nicely described those earlier. All of these have, just like the expansion coverage, all of these have potential unintended consequences. So it's humbling to me, having studied healthcare a bunch, having gone and worked in D.C., understanding the legislation, to sort of think about, gosh, there's just a lot could happen. And so I just hope, what I tried to constantly be thinking about is where's the place where if we don't do it right, we're going to look back and say, oh, we should have done X. So I think that, but it's complicated legislation, and there are some places that are more vulnerable than others. Another key provision of reform, and I'll just go through this briefly, things like not having lifetime limits on policies, things like not allowing plans to have pre-existing condition exclusions for kids, and extending coverage on family plans for adult kids through their 26th birthday to try to hit that very likely to be uninsured group. Various things like this that are insurance market reform. So there are kind of 3 big components to the legislation: expanding coverage, either financing that coverage expansion, and insurance market reforms like these. And many covering preventive services, many have argued that this recent uptick that we saw in private health insurance costs was partly attributable to the costs of some of these insurance market reforms. I haven't seen a study of that. In terms of the changes in Medicare financing, reform was somewhat less popular among Medicare recipients, partly because of their sense that the legislation reduced Medicare spending by about $450 billion over a decade than it otherwise would have been. So if you look how much Medicare spending would have been, that's about a 6% reduction in Medicare spending. Beyond, if you aggregate up what Medicare spending is expected to be over that period. And partly, much of that reduction is coming through lower payments to providers. And this is partly why I asked that question to Amitabh this morning, through reductions in annual updates for hospitals and skilled nursing facilities and so forth, reductions in what are called overpayments to Medicare Advantage private plans, an independent payment advisory board, which is to some extent aiming to be modeled after the Fed, but to try to recommend changes that would be automatic to Medicare and Medicaid to slow growth in those programs if spending goes too high. There aren't many changes in cost sharing, though, or in Medicare eligibility. So they could have done some of this by changing copays or deductibles or age of eligibility, but that wasn't touched. And then there was the filling the Part D donut hole, as Cosley talked about. So just in terms of thinking about how complicated, though, any policy would be, look at this, and this is just, there's nothing special about Medicare Advantage, but it's just to give you a sense of the heterogeneity and why the politics of things were often complicated. So one of the big sources of savings in this bill to finance the coverage expansion is lower reimbursement to Medicare Advantage plans. And these are private insurance plans that Medicare recipients can opt into in lieu of fee-for-service. What you see is that there are some states where almost half of their Medicare recipients are in Medicare Advantage plans, whereas in other states, almost none. It's very interesting to me, like Pennsylvania, where I now live, almost 40%, versus Delaware, right next door, less than 4%. And why that is, I'm actually doing work with someone at Wharton on this, what drives this heterogeneity. But as you can see, a policy that is going to lower Medicare Advantage reimbursement politically, suddenly that senator from Arizona or Minnesota might say, wait a second, I'm not so sure. Whereas the Delaware or Vermont one might say, this is great, let's crank it up. So it was, any of these things would differentially affect certain groups, certain states, and it just made it the politics were incredibly complicated of it. And the Medicaid expansion, so Medicaid's a state-administered but federal and state-financed, and it currently insures about 60 million people in the U.S. And the reform is going to expand this coverage up to 133% of the poverty line. But governors were not thrilled about this prospect because suddenly there'd be this new cost imposed on them. States, as you all know, are in really bad shape. I think the state government in Texas, I don't have a good sense. I think it's doing better than most in terms of fiscally, but states are in a very difficult position and it's not going to get better. So partly because of this, there's a much higher federal match for this expansion population, these newly eligible for Medicaid, than for those currently eligible for Medicaid. So it starts out at 100% and it drifts down to 90%. And we did this report at the CEA showing that actually states were going to come out ahead because they're currently spending a ton of money on uncompensated care of their own money, and this was going to bring in a bunch of federal money to do that, but it didn't help with certain governors much. But we tried. And some have argued that this is unfair to those states. Like Minnesota, for example, doesn't get much of a benefit from this because it had already expanded coverage beyond 133%. The individual mandate and the employer responsibility, these are big features to the bill, and these were also very controversial, but they have a huge effect on how many people end up getting coverage in the exchanges and so forth. So the mandate, as you know, it's now headed towards the Supreme Court, whether it's constitutional or not. It starts out pretty small, just $100 or 1% of income in 2014 if you don't get coverage. But that'll rise by 2016 up to about $700 per person, or 2.5% of income. And this was included to sort of both increase coverage and reduce strategic behavior, so that you didn't have someone saying, I'm uninsured today, I just realized I've got a problem with my knee. I've got to go get surgery. I'll sign up for 3 months and then I'll opt out. And so it's partly aimed to reduce that kind of strategic behavior. The employer responsibility requirement is also controversial as well. So if you're an employer with fewer than 50 employees, you don't have to do anything. You don't have to provide coverage at all. So it's plausible that many of those, we saw earlier that I think 72% of firms from 10 to 24 employees are offering coverage. Maybe some of them will decide not to offer coverage as a result. There'll be no penalty. But for larger employers, if they drop, there'll be a $2,000 penalty per worker. It is possible that some employers will say, that's fine, I'll pay $2,000 per worker, give a little more in wages, and I'll come out ahead, and so will my workers. So that this issue of how much will employers drop, CBO doesn't think that they will much. This is actually an area of some controversy. So I think the place where economics, I think, loomed largest in the discussions in, as the legislation was crafted both in Capitol Hill and back, in the executive branch, was the generosity of subsidies in the exchange. And this is a really sort of tricky area because, let's say, for people with very limited incomes, you want to make, you don't want to necessarily have a mandate and then impose really high costs on them, making them much worse off economically. But then you have to basically, you have to phase that subsidy out if you're not going to give it to everyone. And so you can see this here, this idea that for a $12,000 policy, if someone who's earning, a family with $33,000 in income a year is going to get a subsidy of about $10,500. They're only paying $1,500 for that policy, okay? But as their income grows, they're going to pay more and more and more and more. Now, one of the things that was on the table was let's only go up to 300% of poverty, $66,000. But if you do that, then you actually have to cut that subsidy faster. You need the slope of that thing to be steeper to get that same size cliff, and that imposes a bigger disincentive on people to work, because if it's steeper, then someone's saying, oh, if I earn another $1,000, I'm going to lose $250 of that in lower subsidies. So where do you kind of balance? How do you balance optimally this issue of you don't want too many people to be getting the subsidies because then the bill is really complicated, but if you cut it off too quickly, you'll have terrible incentive effects. And this is where it ended up. And there are going to be these subsidy cliffs, especially in high-cost states. There will be someone whose income is $87,900 and someone else at $88,100, and there will be an article in the New York Times or the Wall Street Journal about those families, and one very happy and the other not so happy. The excise tax on high-cost plans, this is an area where basically how am I doing on time? I'm not doing great, I think, but 5 minutes, okay. So excise tax on high-cost plan, this was really, in the legislation, really the big lever for, quote, bending the cost curve in the private sector. So right now, all of us, to the extent that we have employer-sponsored health insurance, it isn't taxed. So that acts as a sort of subsidy for us to get more generous health insurance than we otherwise would. And a lot of health economists think that's part of the reason we have relatively high healthcare spending in the U.S. We get policies that are too generous because of this. And those subsidies, by the way, are biggest for the highest income people who have the highest marginal tax rates. And so this basically tries to kind of, in a backwards way, eliminate that that subsidy on the margin for very high cost plans. So if the premium goes beyond that threshold, the insurer has to pay a certain amount to the government, but basically that will have the effect of it's similar to eliminating the tax subsidy beyond those thresholds. And whether so it was delayed until 2018. This was something that, let's say, I know many unions were actively opposed to because many of their members have policies that are more generous than these thresholds. And so it was delayed until 2018 so people could have some time to prepare for them. But this was one of the most controversial provisions. Not quite, okay. And the public plan, I'm not even going to talk about that, didn't happen, but it was in the mix for quite a while. And other controversial issues, death panels, abortion. We weren't asked to weigh in on abortion either, not class act, and we also weren't, how should abortion be covered or that kind of thing. This was an area, the treatment of coverage for services related to abortions was a very controversial area. Bart Stupak, Louise Slaughter, and others became sort of down to the ninth inning, 2 outs. This was a question of, this was kind of one of the things that could cause it to go one way or the other. I think one concern that people had, especially as things went on and the economy wasn't totally back on track, was, is this going to stimulate or dampen job growth? And so CEA prepared this report, The Economic Case for Healthcare Reform, arguing that it would help the economy, help economic growth, help wages, all this stuff, but not everyone was persuaded by it. So the legislation ultimately passed. Now what lies ahead? Early deliverables are being implemented, so there are these, the big stuff doesn't really happen until 2014, but there are various sort of smaller things referred to as early deliverables that are already in effect. So for example, family policies right now have to cover adult kids through their 26th birthday. And so in these, there are exceptions, there's grandfathering, but for the most part, they have to be covered. And what you see actually perhaps surprisingly, perhaps not, is lo and behold, last year in 2010, the first year this was in effect, there was an increase in health insurance coverage among young adults relative to everyone else. So it looks like this is a place where the legislation is kind of having the effect that it was expected to have. But not all things are working as predicted. So there are these other early deliverables, high-risk pools, where people who are unable to get private insurance because maybe they have a pre-existing condition are supposed to be able to get subsidized coverage, and CBO and CMS projected enrollment in these things of about 375,000, 350, 400, somewhere in that neighborhood. And last time I checked, we were at about 25,000. So it was off by more than an order of magnitude. And that's not to say that, to put down CBO or CMS. It's just to underscore this is really complicated stuff. And estimating what exact effect it's going to have is not easy. The lawsuits are working their way through the courts. The premiums healthcare premiums are still rising rapidly, so by 9% last year. I think a real issue is these state-based health insurance exchanges. How aggressively, how enthusiastically will states be in setting them up and in making the experience a good one? So think of when you go shopping on, let's say, Amazon or some other site that is sort of well done. It's a good experience. You go on. It's pretty clear how to do it, and start to finish, you go on. You want to buy 3 books and a couple of CDs, and you check out, and your purchase is done, and it's all smooth. If the exchanges succeed in having a good experience for people when they log on, or, because a lot of people will do this on the internet, more so than with Medicare Part D, because this is going to be a younger group and generally, and computer use differs by age groups. So how well they do in making that a good experience and encouraging insurers to participate and so forth, I think is going to be a big determinant of how much of a kick we should see in health insurance. Same kind of thing holds for Medicaid. How aggressively will states be about trying to do outreach to make sure that people who are eligible get covered? And that is something CBO can't really know that's hard to know, but it will be interesting. So this is my very last slide. I think everyone I've talked with after I was done with this stint said, but it doesn't do enough to slow healthcare costs. And yeah, I mean, there are a lot of things in there that are hoping to slow cost growth, but as others this morning underscored, this isn't an easy thing to do. CMS is projecting a big slowdown in spending on Medicare. Medicare spending per recipient, they're projecting this is going to slow down a lot over the next 20 years. And if that happens, that's great. We'll see if it does. What will happen with will employers drop and lead people to go to the exchanges? There are many uncertainties here. And delivery system reforms, I haven't touched on these at all, but a lot of people hope that things like bundled payments and accountable care organizations, Medicare is going to try to do, and Medicaid for that matter, are going to try to do some initial pilots with these things to get them going, to see if they can lower costs by basically giving providers better incentives, giving them a lump sum and letting them sort of figure out how to pick treatments and not get reimbursed for every little service. Private sector costs are going to be a smaller share of the healthcare system in the years ahead. And what are the excise tax and the exchanges and other things going to do? I think there's just a ton of things that's going to be fascinating. It's a fascinating time for people like Vivian and me and Marty and Amitabh and others and Kosali and David to be studying this kind of stuff. So it's going to be a fun time for us, and I hope it goes really well. So in any case, I'll stop there.
Thank you very much for your comments. I was particularly gratified by your comment about how good the Medicaid expansion would be for Texas. I believe you're the second person in the medical center that said that out loud. As the people at my table know, I'm the other one that says that because I run a Medicaid HMO for the public hospital system here in Houston. So it actually will be fabulous for all the residents of the city of Houston and the whole state to have so many more people covered by Medicaid because they are all uninsured right now. Editorial comment aside, my question for you. One of the things that really has worried me about the bill is actually what you talked about with small employers. What we see in Texas already is a much lower percentage of small employers offering health insurance now than nationally, and that number seems to be shrinking very rapidly. So instead of increasing insurance, there's a number of us that sort of fear that small employers will just get out altogether. I wonder if that was something that you guys talked about or thought about, or what the economics of that might be.
Yeah, I think it's a great question. At some level, I think the response of employers to this legislation is, I don't know, one could argue that's the place where there's almost where it's almost hardest to predict. There's a pretty big interval in terms of plausible outcomes there. I think it seems likely that, well, let me say one thing. I'm very confident that people who work at small businesses, a much larger share of them, will have health insurance once this legislation takes effect than would otherwise have had it. Whether they will have it because their employers are offering it or because they are going to these exchanges and getting the subsidies, I'm not sure. So what that split will be. But right now, people who work in small businesses, if you control for their age and their gender and their state, they're like 2.5 or 3 times more likely than people who work in large businesses to be uninsured. That gap is going to shrink enormously. I don't know if it'll get totally eliminated, but so they're going to be more likely to be covered. I think it's plausible that a lot of small businesses are going to do the math, and they're going to say, well, I could do one of two things. I could either offer this coverage, and maybe I'll qualify for this small business tax credit, okay, but the small business tax credit won't benefit all. It's their size criteria and average wage criteria. Or they may say, or I could not offer, pay my workers slightly higher wages and let them go to these exchanges and get the subsidies. And so it could be for small employers, they and their employees may be somewhat better off as a result of this, and because of these higher wages and so forth. So I think it's very plausible, and CBO projects that a number of small employers will drop. Whether it will happen differentially in Texas, I'm not sure. But there's some who think it would be great if a lot of people go into these exchanges, because the more people who are there, the more bargaining power the plans will have with healthcare providers, the more the more robust and I think efficient the system will ultimately be. But I think it's a great question, and I think my guess is that of small employers today that are offering coverage, I'll bet most of them will continue to offer coverage, but some will definitely drop. They'll just do the math, and it'll be better.
If the Supreme Court were to rule that the mandate provision was unconstitutional, but the rest of the bill was constitutional, what would that do to the bill? And are there other alternatives to take the place of the mandate if that's what the outcome would be?
Yeah, that's an excellent question. I think the CBO has looked into this issue of what would happen to coverage. And so suppose you left everything else the same and you just eliminated the mandate from the bill. So that's that penalty, the 95 that grows to 695. If you took that out, coverage in the exchanges and in Medicaid for that matter would be lower. And costs would be a bit lower, but not much. So I can't remember the exact number, but I think it's in the neighborhood of the coverage increase would be, instead of 32 million, more like 16 or 18 million. But the costs would not proportionally fall as much, because people who would opt in, it's this adverse selection thing, would be the people who have higher costs. And so the healthy folks would tend not to opt in, because there's no mandate, and they can always just opt in whenever and get the subsidies if they need it. And so my sense is, but there's a lot of it, as I said, that 32 million, there's a lot of uncertainty around, and they spent many months developing the model to optimally predict that 32 million. Pulling out this one provision, how it would affect things, it will have a big effect. But how big is, I think 50% is plausible. Of 50% of a lower increase in coverage. The $95, by the way, in year one, that's not much. So that you could argue, but people may just sign up anyway in 2014 knowing that a bigger penalty is coming down the pike. So we'll see. Yeah.
50 plus employer, what are the subsidies for dependents or are?
What are the subsidies for?
Well, it's a $2,000 subsidy if the employer opts out to the employee, but what about the dependents?
No. It is it's if the employer opts out. So let's say Rice University on January 1st, 2014 said, we're done. We're not doing health insurance anymore. Okay. So Rice University would have to pay $2,000 per full-time worker as a penalty. And then their workers would go to these exchanges and would get subsidies that depended on their income. So the president of Rice University wouldn't get a subsidy at all. The president, I'm guessing the president makes more than the president would get no subsidy, but someone who was earning $30,000 a year would get a very large subsidy. So the subsidies are a function of income, and it is, and that's true for whether your employer's got 50 or more, or whether it's less than 50. The point, but the employer with less than 50, if they don't offer, no penalty. So, to get back to that question earlier, a bunch of them could decide, why don't I drop and let my workers go get the subsidies in the exchange?
And I'm thinking about employers that subsidize
Right. But I guess I don't think I'm nailing your question though. So the employers that subsidize coverage for their dependents right now. So I think that the legislation already now is requiring them to provide that coverage, at least to their kids. And so I think that's already in effect, I think.
One of the challenges that was discussed but not included in the act was the payment formula for physicians, the sustained growth rate formula. So, and I understand the savings on that were included in the scoring, and now we're facing another impending cut that Congress, we assume, will fix somehow. And this has just been an ongoing challenge that I think many people hope would be addressed as part of this. Could you share with us some of the discussions around that, whether to include it or not include it, or other ways to deal with that?
Right. It has. This was. I'm sure there was some discussions of that. I wasn't privy as much to the discussions on that particular issue. I think it is, it's a source of. It's not a great situation we're in right now, where we basically have a current reimbursement rate formula that is going to decline very soon, but then we keep pushing back that date, and we don't really sort of confront the issue. And I think the likelihood of resolving that in a long-run way anytime soon, I don't know, I'm not super optimistic. In other words, it may just, how long have we been doing this right now? You would know better than I. For several years, right? So do I think that in the next year or 2 or 3 years, it would be great if the policymakers could get together and work something out that was sustainable and that was sort of acceptable to the various stakeholders, but I don't know. That usually, in terms of things that I worked on, that was usually just a separate thing. So I'm sorry I can't give a more satisfying. I think for anyone to predict right now what's going to happen in D.C. is hard, and that has, even in a more in an easier political environment, or it was hard. So I think now it's doubly tricky.
I want to ask you, it sounds like these exchange policies are going to be individual policies people can take from employer to employer. Is that correct?
And family policies too, yep.
And family policies. Well, the way it works in the individual market today is typically insurers will close blocks of business and issue a new policy with different benefits and then open that for new business. So it's sort of like the reverse of a Ponzi scheme, where you're in a block that's dwindling the longer you're in it, and the higher the costs go up. Right. And so it's to your benefit to switch, but you have to prove your health to do so, and that makes it difficult for a lot of people. I'm wondering, is there anything in the law that prohibits insurers from closing blocks of business? No,
but I don't think the insurer can prevent you from going into that other new block of business that they open. So in the exchanges, I don't think that will be an option. There are these subsidies, and they're going to be, to the extent that let's suppose that you're in the midst of a liver transplant, and they're closing down your block of business. I don't know if it may be prohibited. I'm not sure. But even if it were, you would be able to switch into a different one. That is sort of a condition. You can't exclude people.
Do you have any idea what the premiums would be switching from one block to another?
It depends, but you're going to have these premium subsidies. You're going to have premium subsidies that are that will sort of determine. Can I get the slides back? I don't know if anyone. Okay, that's a good slide, but not the one I want. In any case, the premium subsidies will be set so basically what people will pay will be the difference between this subsidy and $12,000 in my example. This is for a family policy, a family of 4, for the second lowest cost policy. So one thing I should have mentioned that I think is is a really good feature of the legislation is that to the extent that you choose a policy that's more expensive than the second lowest cost silver policy. Silver means actuarial value of 70%. Second lowest cost silver policy, you pay the full price difference. So if there's a $12,000 policy, you say, I really want that $14,000 policy because that's got my providers in it. That's fine. You get the subsidy here, but then you have to pay an additional $2,000, whether you're in poverty or you're at 400% or more. So they are, that is actually, I think, and this is likely to lead people to make more efficient decisions about which plans they're going to select. Right now with the tax subsidy, to the extent that you choose a less generous plan, you don't get the full reward from that. And this, I think part of the reason that Medicare Part D actually turned out to cost a lot less than people projected was that this is a feature of Medicare Part D, that you pay the full cost difference between your plan and, let's say, some benchmark plan. Gives people skin in the game. Maybe they choose a plan that's got a lot of generic coverage and not so much of the fancier brand drugs, and that I think will be a very powerful cost control device. I think that could be at least in terms of controlling costs, that could be a good thing. And how? In your example, it would depend on the specific premiums of those two policies relative to the second lowest cost silver plan. Yeah.
In your modeling for the Medicaid costs or savings to Texas, you indicate there'd be a big savings to the state, but in the modeling, is that a savings to the state as a whole, or is that savings to the state government? Because the issue here in Texas has been that the state government would have to come up with significantly more to cover that, where the savings might be partly at the local level, say at the county level.
Right. So there may be some of this. When I say state, I should have state and local, because a lot of local governments are spending money on uncompensated care as well.
Yeah, and that was a pushback at the state government, of course, with the state budget short.
Well, so obviously it's more complicated on the front lines of dealing between the states and localities, but at some level, in the aggregate, state plus local governments in Texas will be a lot better off. And how they will split that, like will the state say to local governments, look, you're saving all this money, we can transfer less money to you, and you're still better off and we're still better off. I don't know the details of that. I'd like to think it will happen, but maybe it's more complicated here. But I will say, if there is a state that serves to benefit from this legislation, it is right here.
I believe that. You put your finger right on it, though. There it is. The counties versus the state government.
Right. I don't know. I just wish it is. Yeah, the counties versus the state. That'll be an interesting discussion. But I do think the folks in Texas, and I know I'm not trying to mess with Texas. So, but it will be the amount of resources that will come into this healthcare system as a result of this legislation are huge. So I would be surprised if people working in the healthcare system, and not even just the people working in the healthcare system, but I think people throughout, a third of adults are uninsured, and that will change a lot under reform. So I don't know if I don't know how the exchange will go here and the Medicaid outreach and all that, but I think it will be it'll be fascinating to watch it unfold. Yeah. Something. Yeah. Okay. Great. I'm done. She's kicking me out.
Well, thanks, Mark. That was extremely informative, very helpful, and we're delighted that you are interested in coming and studying what will go on in Texas after reform. You're welcome to come at any time. Just in terms of sort of dwelling on our high rate of uninsurance, I should have reminded you that this conference is being webcast, and so don't be surprised if there's a little greeting party for you at the airport on your way out. So we're going to take one last 15-minute break, and then Martin Gaynor is going to be talking at 1:45.